There is a maintenance tunnel beneath the city of Chicago that has not appeared on any official city map since 1959. It runs for approximately 400 feet beneath what is now the parking structure of a major downtown hospital. The tunnel does not connect to the hospital above it. It predates the hospital by at least 30 years. And at the far end of it, behind a poured concrete wall that building inspectors have noted in their reports but never ordered removed, there are doors. Metal doors. Industrial grade. The kind designed not to keep people out, but to keep conditions stable inside. The city has no record of who poured that wall. The hospital above it has no record of what the tunnel was used for. The maintenance workers, who first documented the doors in 1987, filed a report with the city's Department of Buildings. That report was logged, assigned a case number, and closed 6 weeks later with a single notation: resolved historical infrastructure, no action required. Nobody on the current staff of the Department of Buildings can tell you what that notation means or who authorized it. The doors are still there. The wall is still there. And whatever is behind it has not been opened in living memory. This would be easy to dismiss as a single urban curiosity if it were not for what is sitting in the National Archives in Washington, D.C. right now. A document collection spanning 11 boxes, catalogued under Record Group 112, the records of the Office of the Surgeon General of the United States Army. Inside those boxes are the planning documents, requisition orders, and construction reports for a program that has no Wikipedia page, no museum exhibit, and no mention in any standard history of American medicine. The program ran from 1909 to 1933. It was funded through a combination of War Department appropriations and private endowments, whose donors are listed in the records only by initials. It built medical facilities across the continental United States and parts of Western Europe at a scale and to a specification that the official history of that era says was not yet technically possible. And when the program ended, every facility it had built was sealed, not closed, not repurposed, sealed. The records use that word specifically, methodically, across dozens of individual facility entries, sealed and transferred. Transferred to whom, the records do not say. The transfer orders reference an administrative body designated only as the Office of Continuity. No such office appears in any other federal record collection. It was not a known branch of the War Department. It was not a known bureau of any civilian agency. It processed the transfer of at least 300 facilities and then, as far as the documentary record is concerned, ceased to exist. To understand why this matters, you have to understand what medicine looked like in 1909 and what these facilities were apparently designed to do. In 1909, the average American hospital was a voluntary institution, meaning it was charitable, meaning it was underfunded, meaning it had between 40 and 80 beds, a surgical suite that would today be classified as inadequate for a veterinary practice, and a mortality rate for post-surgical infection that hovered around 30%. Anesthesia was still largely ether-based. Blood typing had been discovered only 8 years earlier and was not yet standard practice. The germ theory of disease was accepted in academic medicine, but still contested in clinical practice at hundreds of smaller institutions. This was the baseline. This was what American medicine looked like when this construction program began. Now look at what the requisition orders describe. Negative pressure ventilation systems, meaning the air inside the facility was kept at lower pressure than outside, so that contaminated air could not escape. This technology was not standard in American medical facilities until the 1960s. Radiant floor heating controlled by zone valves, a construction technique that American engineering trade journals were still describing as experimental in 1935. Water filtration systems capable of producing what the requisition documents call sterile grade output, a specification that exceeded the technical capacity of most municipal water systems of the era by a significant margin. And in several facilities, something the construction reports refer to only as the resonance array, described in associated documents as an atmospheric treatment system, but never technically defined in any record that has been declassified. These facilities were not built to the medical standard of 1909. They were built to a standard that medicine would not officially reach for another 50 years. And they were built underground. Not partially underground, not basement level. The construction reports specify, across facility after facility, that the primary treatment floors were located between 40 and 120 feet below grade. Surface structures existed, described variously as administrative buildings, supply depots, and in 2 cases as private residences, but they were access points only. The actual facilities were below. In locations that the construction reports describe with geographic coordinates but no place names. When those coordinates are mapped against the modern landscape, they fall beneath parking structures, municipal parks, private estates, and in at least 6 cases, beneath facilities that today operate as hospitals, with no documentation of what lies below them or why their foundations were poured the way they were. The question that the construction reports refuse to answer is simple. Who were these facilities built to treat? And why did the people building them believe those patients needed to be 40 to 120 feet below the surface of the earth? There is one document in Record Group 112 that comes closer to answering this than anything else in the collection. It is a memo dated the 14th of March 1917, written by a senior medical officer whose name has been redacted. It is addressed to the program's administrative director, whose name has also been redacted. It concerns a facility designated in program records as Station 7, whose geographic coordinates place it beneath what is now a public park in central Ohio. The memo describes a patient census review. It notes that Station 7 currently holds 412 patients under what it calls extended continuity protocols. It notes that the facility's atmospheric treatment system is functioning within acceptable parameters, and then it contains a sentence that has no clinical analog in any medical literature of the period. It reads, "The patients at Station 7 have not required external nutritional input for a period now exceeding 14 months, and their condition remains stable within projected variance." 412 patients, 14 months, no food, stable condition. That sentence was written in 1917. It was classified. It sat in a federal archive for decades. And the facility it describes is still beneath a public park in Ohio, sealed, with no living person authorized to tell you what is inside it. The program did not operate in isolation. This is the part that requires you to hold several documented facts simultaneously and let them speak to each other without forcing a conclusion too quickly. Because the conclusion they point toward is not comfortable, and the documentation behind it is solid enough that dismissing it requires more effort than examining it. In 1910, 1 year after the underground facility program began, a conference was held at Jekyll Island, Georgia. You may know this conference for what it produced, the foundational framework for the Federal Reserve System. What is less discussed is the attendee list's secondary profile. Of the 7 men present at Jekyll Island, 4 had significant financial ties to the private endowments funding the underground facility program. Their initials appear in the Record Group 112 donor lists. This does not mean the Federal Reserve and the underground hospitals are the same project. It means the same private financial network was simultaneously restructuring American monetary policy and funding the construction of 300 sealed underground medical facilities built to specifications 50 years ahead of their time. These are not the same thing, but they are the same people. And when the same people are doing 2 very large things at the same time, in secret, the question of why they felt both needed to happen simultaneously is not a paranoid question. It is the only reasonable question. In 1918, the Spanish flu arrived. It killed between 50 and 100 million people worldwide. It killed more Americans in a single year than died in combat in the entirety of the First World War. The official history of the American medical response to the Spanish flu is a history of improvisation, overwhelmed facilities, churches converted to wards, hotels pressed into service, nurses working without sleep for weeks, a system simply not built for what it faced. Every historian of the period documents this. The American medical system in 1918 was inadequate for the scale of the crisis it confronted. Except that in 1918, according to the Record Group 112 documents, there were 300 underground facilities across the continental United States built to specifications that exceeded anything available in surface medicine, capable of atmospheric controls that would have been precisely suited to containing and treating a respiratory pathogen of catastrophic scale. None of them were used. No patient from the Spanish flu epidemic was ever directed to one of them. No public health official of the era referenced them. No after-action report of the crisis mentions their existence. 300 facilities, 100 million dead. The facilities stayed sealed. The reason the facilities stayed sealed during the worst medical emergency in modern American history is something the Record Group 112 documents do not address directly. But they do contain a document from November 1918, the month the Spanish flu peaked in the United States, that clarifies the program's position on the crisis. It is a 2-paragraph internal memo. The first paragraph notes that the current surface medical emergency does not constitute a triggering condition under program protocols. The second paragraph reaffirms the instruction that no station is to be opened, accessed, or referenced in any external communication for any reason, not meeting the threshold of a primary continuity event. The Spanish flu, which killed 675,000 Americans, was not a primary continuity event. Whatever these facilities were built to respond to was considered significantly worse than that. The program formally ended in 1933. The closing documents are administrative, almost bureaucratic in their flatness. Each station is listed. Each entry reads the same way: sealed per standing order. Transferred to Office of Continuity. Status: maintained. What maintained means in this context is clarified in only one place in the entire collection. A technical addendum attached to the closing report specifies that maintained means atmospheric systems operational, structural integrity, monitoring active, access restricted to authorized continuity personnel on rotating schedule. The facilities were not abandoned. They were being actively maintained in 1933 by personnel on rotating schedules under the authority of an office that does not officially exist, to preserve their status for a triggering condition that had not yet arrived. Today, those facilities are still there. This is not inference. The geographic coordinates are in the record. The construction specifications are in the record. Poured concrete does not unmake itself. Negative pressure ventilation systems do not dissolve. The metal doors beneath Chicago are consistent with the ceiling specifications in the 1933 closing documents. The coordinates that fall beneath modern hospitals and parking structures and municipal parks are consistent with the distribution map that can be assembled from the Record Group 112 facility list. The maintenance personnel on rotating schedules were authorized in 1933. Nothing in the documentary record indicates that authorization was ever withdrawn. There is a historian at a Midwestern university who spent 4 years requesting supplemental access to the redacted sections of Record Group 112. Her requests were processed, acknowledged, and denied 11 times between 2009 and 2013. The denial letters cited National Security Review as the basis. In 2013, she received a letter informing her that the relevant redacted materials had been transferred out of National Archives custody to an agency whose name was itself redacted from the transfer notice. She published a paper about the collection in 2015 Inches, a peer-reviewed journal of medical history. The paper received 4 citations. It has never been covered by a mainstream outlet. Her follow-up FOIA requests since 2015 have received no response, not denial, no response. The requests were received. She has the postal confirmations. The agency responsible for responding has simply chosen not to. This is the architecture of the thing. Not a dramatic revelation, not a single smoking document. A structure of omissions so consistent and so procedurally careful that it can only be the product of sustained institutional intention, records that exist but cannot be fully accessed, facilities that are documented but cannot be located by any official who is asked about them, maintenance schedules authorized by an office that does not officially exist. A triggering condition that is never defined but is considered more serious than a pandemic that killed 100 million people. The concrete wall in Chicago is unremarkable. You could walk past the parking structure above it every day of your life and feel nothing. The doors behind it are standard industrial grade. The tunnel leading to them is maintenance infrastructure, historical, no action required. But somewhere in the record group, 112 collection in Washington, there is a document with a geographic coordinate that matches that parking structure. And on that document, in the column marked status, someone typed a word in 1933 that has not been updated since. The word is maintained, present tense, not was, not had been, maintained. As of the last entry anyone was authorized to make, those doors were still being checked. The systems behind them were still running, and whatever the program built them to hold was still inside, waiting for a day that whoever funded this decided had not yet come.